I'd like to introduce now Associate Professor David McBride, the University of Otago. David McBride is an occupational physician and Associate Professor in Occupational and Environmental Medicine at the University of Otago, New Zealand. He has recently completed a study of New Zealand contemporary veterans examining the relationship between post-traumatic stress injury, health, well-being and multi-system illness. A reservist for all of his adult life, he has served in Northern Ireland, East Timor and Afghanistan. To speak on veteran mental health and well-being study, the New Zealand context, Professor David McBride.
This is the 150th, coming towards the end of the 150th anniversary of the Maori Wars in New Zealand, which were pretty important at the time. Well, we're a young country, and here is a warrior with a meri, which is a jade or greenstone club. First position, second position, third position, temporal bone fracture. Not very nice at all. And there wasn't much veteran support in those days either. Veteran support in New Zealand has changed post-Vietnam. They probably wanted to change it for the Vietnam veterans as well, but they didn't get away with that. They couldn't get away with it because of political reasons, obviously. Very strong lobby group, Vietnam veterans. So the Veteran Support Act 2015, the Australian Repatriation Medical Authority statements of principles apply, but you have to, a list of conditions, but you have to inquire those conditions on deployment to get cover, which is difficult. Otherwise, there's this ACC thing of more likely than not, which means 51%, which means an odds ratio of 2 or a hazard ratio of 2 as well. So it's a difficult standard of proof. The NZDF, not as many PA nowadays. We essentially in Linton have a battalion group, fully supported, which we can deploy. Small, so the total number of 2,000 Navy, 4,000, 4,500 Army, Air Force, 2,000, 554, total of about 9,000. And the currently serving veterans, about 20,000 since Vietnam, but we do not have accurate figures, which is unfortunate. So we really don't know how many veterans are out there. Younger veterans won't put their hand up because they think of the Vietnam veterans who are getting grumpier by the day, and then the World War II veterans who are even grumpier still, so that's all good. Civilian veterans, lest we forget we've got civilian veterans. Here's an anaesthetist in East Timor, and we had nurses in East Timor, a small but important group, also included in the Vietnam veterans, about whom we do not know much because there's so few of them. So I was trying to take a positive slant on this whole thing about PTS. We need to know about post-traumatic injury, but we also need to know about well veterans, because most veterans, let's face it, are well, they do well. So what makes them so? What makes them well? So what are the risk and protective factors for PTSD in contemporary veterans? What indicates well-being, and what do we look at discharge, civilian, military-civilian transition? What questions do we ask to make sure people are going to be okay, and if they're not okay, how do we get them to supports? So these are the things we did, the usual things for PTSI, post-traumatic checklist, military, EQ5D, which we'll talk about shortly, the Euroqual 5D for good health. We looked at social support, psychological flexibility, the sleep score, and the GHQ-12. Some of these things to control for confounders, obviously. Survey admin went out to deployed veterans, of whom there were 4,822 at the time, but 1,038 of those were veterans. And they got an email on the NZDF system, which is difficult to access unless you're actually serving and logging in every day. But this is the only way we could get to them. 2001 invitations, 1,761 responses, complete 1,518. Questionnaire was a bit long because we looked at multi-system illness as well. Nicola Fear told me not to, but then we got 2 grants, so we had to, so that's good. The response rate was somewhere between 21 and 30%. We're nearly sure of that. And if you look at those with PTS, PCLM, no, yes, much the same. Results, we got a reasonable distribution of younger veterans. We think we haven't had a significant deployment now. Well, we've had a deployment to Iraq, but it hasn't been large. So quite happy about the age distribution really. So PCLM greater than or equal to 45, which is clinical PTSI, if you like. So on the left we have categorical variables, some used to control for other things. So if you look at being deployed, if you're deployed, you were slightly less likely to have PTSD. If you're a male, you are more likely to have PTSD, and I can give you copies of these slides if you like. So if you touch the red line with the black bar, then it's significant, right? And the red dot in the middle gives the, and the figure at the bottom gives the level of the risk. So twice as likely to have PTSD if you're a male, female slightly less likely. Ethnicity, if you're a Maori, you were slightly more likely to have PTSD. No, sorry, if you had an other ethnic, in the other ethnic groups, apart from Pākehā and Maori, so Pākehā European, Maori obviously Maori. If you're in the other group, you're slightly more likely to have it. Trauma, of course, increases it. Alcohol, slightly decreased, but not significantly so for PCLM greater than 45. And sleep, quite protective. Now, we know about this now, sleep, quite protective, but sleep, poor sleep, is indicative of a number of other things going on, such as pain, distress, multiple pharmacy, those kinds of things. And being flexible, the acceptance and action questionnaire, whatever being flexible is, we included in there. All good. EQ5D, visual analog scale, I don't know whether you know this, but I think it's a good measure of well-being, wellness. It asks about the best health you can imagine and the worst health you can imagine. Imagine, right? If you ask me today, I'd be about 83 on that because I'm standing up here, but other days I'm sort of 87, so I'm okay, right? But it's good. It's a vertical scale, and when you think about it, it's a good measure of, you know, what's the best health you can imagine today? Yeah, good. The domains are important too, because you can adjust quality adjusted life years with this, and this is where you're going to get the money from Treasury, right? If you can prove that you can prevent expensive conditions and disability, then you're going to help. So you assess mobility, self-care, usual activities, pain and discomfort, anxiety and depression. EQ5DVS scores, 83 to 85 is the modal value there, so that's all good. But some people had terrible health that they imagined. Here we have the EQ5D domains, and you can see the big spike in the middle there, the maunga one, pain and discomfort. So going along the bottom, we've no pain and discomfort, then slight pain and discomfort. So a significant number of people there with slight pain and discomfort, and the other blue line, high anxiety and depression, with the rest of them probably tracking okay, more or less. So the pain's a significant thing, probably in there with the sleep and the anxiety and depression and reducing the overall quality of life. And this is because, of course, we put the joints under a lot of stress these days in military training, probably more than we've done before by jumping out of the back of a unimog or whatever we did. And here we did a previous study, lower limb injuries, over 11 months, almost a year. And you can see that upper leg, knee, lower leg, ankle in particular, lots of musculoskeletal injuries. And that's all going to come to haunt us, I think, in terms of osteoarthritis in the future. So that's one thing we could do to improve overall well-being, look after joint health. Okay, EQ5D visual analog scores. So women were probably more likely to feel good. Ethnicity, less likely to feel. Men were less likely to be well overall. Ethnicity, once again, the other ethnic groups. Something going wrong there. We're not connecting those people. Being deployed had a protective effect up on the top there. Next we have trauma, obviously, made you feel less well, the effect of trauma. And once again, the GHQ score, negative effect, flexibility and sleep being protective. And those were continuous measures, so that's why the confidence intervals are so low. So there's something important in there that we need to sort out. Strengths and weakness, first pan-veteran survey across New Zealand, exploratory analysis, the response rate. We hope to get this published in PLOS 1. They're asking us lots of questions. Why don't we know this? And we said because we don't know it, because we're not good record keepers. Some records are good in New Zealand. We can track veterans. I better not say any more. Good. Quality of life, well-being, health status, importance, the AAQ. Yeah, it's a sort of a negative measure, so we don't know whether the inverse means that it actually means flexibility. Sleep's good. Alcohol needs much more in-depth study, so we'll start that at 5:30. We have to stop shock local joints. The idea is we identify at-risk veterans and refer them to veteran knowledgeable and friendly health providers. And we need both health and social support, the holistic thing, as we know. Now, the next steps, engage with the GPs for me, okay? And thanks and participation to all those good people who helped us out with this study. Now, you won't have heard of Te Pai Mahatonga, the Southern Cross, right? A Maori model of health. Te Mana Hakaweri, autonomy. Na Manakura, leadership, the two prerequisites to do anything. Autonomy meaning really participation, right? Participation of veterans in research. Got to get them on board. Then we've got Wairua, physical health. Mariora, cultural and spiritual health. Te Aranga, participation in society. And Tairoa, healthy lifestyles. And the Maori people also say, He aha te me nui a te ato, he tangata, he tangata, he tangata. What's the most important thing in the world? It is people. It is people. It is people. This is an advertisement for Weight Watchers. That's my dear wife. She's a lot larger than that in real life. I don't remember her being that small. She'll be here later anyway, so that's all good. And whakatauki o nei tahu, proverbs o nei tahu, ma ka hutawa hoki e haere ai te takata. It's the legs that makes a person go. So don't just talk about it. Get out there and do it. Thank you.